Good afternoon. My name is Ellen O'Sullivan and I'm here representing the College of Anaesthetists of Ireland. So the first question is why is Ireland a NAP5? We have very strong links with anaesthesia in the UK. Many of us trained here and many of us work for some time in the UK. So we have very strong links both through the AAGA also and through the Royal College. We have a similar training programme, a competency-based training programme, and we also have a reciprocal, equivalent examination, and we follow standards, AAGBI standards, NICE standards, etc. So, and also the BJ is the official journal of the College of Anaesthetists of Ireland. So what do we bring to the project? We have a very different health service structure with a different private and public mix. We have a different use of depth of anaesthesia monitors in Ireland. And I think it internationalises the projects. All the NAPs to date have been national projects, and we bring an international element, a different country. Hopefully it helps to validate the NAP5 methodology and generalisability of the outcomes and increased impact being an international project. What do we get? It was the first major audit in anaesthesia conducted in Ireland. We can compare ourselves to our neighbours, a large body of anaesthetists. Self-inquiry is important. It's an ethos we must engender in our anaesthetists. And the methodology helped to raise our game. The analysis was very helpful. We had very few cases compared to the UK, and it helps us to reflect our practice, a chance for action and quality improvement. So just an overview of the project. We started with the baseline survey. And the baseline, you can see that has just been published in Ireland because we needed our activity data, and we got that from our baseline. We got our denominator, from the activity study. And then over a 12-month period, we collected all cases of AAGA in Ireland. You'll see there that we conducted our activity study in both the public and in the independent hospitals. And the aim was to get the denominator data for the study because NAP4 had given the denominator data for the baseline for the UK study. So we had local coordinators in all our 46 public hospitals and 20 independent hospitals. And we conducted the anaesthetic activity study over a week. And the data we collected, demographics, anaesthetic techniques, staffing, admission and discharge arrangements. And here's the pro forma on a double-sided A4 page, and it was green, as you can imagine. It was different to the anaesthetic, the anaesthetic sheet, so we could find them easily. But we had a very good response from all the local coordinators, and it seemed very busy, but people filled it out very well, so we're very grateful. So we had 8,049 cases analysed, and our reports and estimated incidence of cases in Ireland 426,600. So nationally, that was the number of cases done per year. In public hospitals, 61% of these cases were done, and in the independent sector, 39%. Now, we didn't expect this result. This was quite a surprise. 39% of all cases in Ireland are done in the independent sector. And looking at data for the UK, it appears about 10% of cases are done in the independent sector, although I believe that might be about to increase. What type of anaesthesia care? We were interested in general anaesthesia in the public hospitals, and 70% of general anaesthesia cases were done in the public hospital. So we got our denominator from this. Now, our denominator was 187,000 general anaesthetic cases, and a population of 4.58 million gives an incidence of GA procedures per 100 of the population per year of 6.5, and that compares with 5.4 from the NAP4 UK snapshot. So this looks at the number of cases performed in a surgery week, and if you look at the blue there in the public hospitals, the incidence in general surgery, obstetrics, orthopaedics and gynecology were the highest numbers, and in the independent sector, interestingly, pain procedures, urology and ophthalmology, there were more cases done in the independent sector than in the public hospitals. This slide shows the number of cases performed in a survey week in the public and the independent hospitals, and the range is much greater in the public hospitals compared to the independent sector, ranging from 4 cases in the week to 405, whereas in the independent sector ranging from 10 to 262. So a huge difference in both. So many small public hospitals in Ireland, which is one of our problems, and the independent sector doesn't support the smaller hospitals. So we also looked at staffing in our survey and found that there are 342 consultants in Ireland versus 8,672 consultants and SAS, so senior staff in the UK. Sorry about that. So in Ireland, say that's the number of consultants we have. In the UK, much higher numbers. So senior anaesthetists per head of population in Ireland is dramatically different. We have 1 per 13,000 versus 1 per 7,000 roughly in the UK. And we're doing major manpower review at the moment in Ireland of our anaesthetic staffing, and this has been very useful and very helpful because we now can use figures and compare and contrast. We don't have an alternate grade apart from medical anaesthetists. So procedures per consultant per year in Ireland versus the UK. The average was 720 cases in Ireland versus 450 in the UK. So again, this is something we are looking to change in Ireland. So this activity study, we were able to look at who works where and when from the anaesthesia point of view. And just a few figures. Consultants present was high in Ireland, 76% of cases, but non-trainees were most senior staff after hours for 2/3 of cases. Where did the activity occur? In public hospitals, 61%, ranged, as I said, in a week from 4 to 402. And 60% of public paediatric anaesthesia care occurs in non-tertiary paediatric hospitals. Again, very relevant data because we're building a big new national paediatric hospital. So when did this activity occur? 70% activity occurs during non-routine hours. This was a document produced by the Department of Health in 2000, last year actually, and this is about reconfiguration of Irish hospitals into groupings, a bit like trusts, and rationalising the small hospitals. And a lot of the data we got from activity study can be fed into this, particularly from a surgical anaesthetic point of view. So this was the article which was published this month in Anesthesia, Who Operates When, Where and On Whom, a survey of anaesthetic surgical activity in Ireland as a denominator of NAP5. The second thing we undertook was the baseline study. There were 8 new cases of AAGA that became known to anaesthetists in 2011. This is obviously an estimated incidence, and I know we're not really supposed to talk about incidents, but if you compare it with the UK, the incidence report there was 1 in 15,000, but obviously we have a much wider confidence intervals because of our size. So a consultant anaesthetist would have 1 patient that experienced AAGA using this data every 36 to 47 years. No hospital had a policy to prevent or manage AAGA. What about depth of anaesthesia monitoring, which we've been debating today? Ireland, 80% of hospitals possess depth of anaesthesia monitoring, but only 62% use it. In the UK, 61% of hospitals possess it and 25% use it from the data, approximately. So routinely used now, as opposed to just using it occasionally, routinely used in 7.7% in Ireland compared to 2.9%, which was the figure we heard this morning in the UK. None was used in any of the AAGA reports in Ireland. An isolated forearm technique was not used at all. And this is the result of the paper which was published again this month in Anesthesia to estimate an annual incidence of accident awareness during G8. So that's the baseline study. So what about AAGA in Ireland? We had 11 cases, giving an overall incidence of 1 in 20,000, so very similar to the UK incidence. We had 5 cases in Class A, the certain probable cases, 1 in Class B, possible, 2 cases involving drug errors, 1 case of sedation, and 2 statement-only cases. And if you look at this, you'll see the incidence, as we heard again this morning, of AAGA when neuromuscular block was used was 1 in 15,500, compared with the incidence when no neuromuscular blocks were used in 1 in 110,000, so a 7-fold difference when you use muscular relaxant. So the 6 cases, as I said, of certain probable and possible awareness, 5 of them, 83%, had received a neuromuscular blocker. There were 2 cases at induction, One was a rapid sequence induction for caesarean section with thiopentone for elective caesarean section after a failed regional. And the second was going from an anaesthetic room into theatre, failure to turn on the vaporizer. None of the AAGA cases involved TIVA. Now, if we look at the incidence or the use of TIVA in Ireland, it's much lower. TIVA, pure TIVA, is much lower in Ireland versus the UK, with only 2.3% of GAs using TIVA as opposed to TCI, and 7.5% in the UK. Our outcomes: 2 cases described tactile perceptions, 3 cases paralysis and distress, and 1 case of pain and distress, and that patient had neuromuscular blockade. Again, we were talking about human factors, contributed to 4 cases: mind the gap, we've discussed, inadequate dosing, this time thiopentone, and 2 cases of drug errors, 1 giving succinylcholine instead of fentanyl for a case that was a sedation case, and the other neuromuscular block in the IV, atracurium instead of diphenol, and that patient was paralysed in recovery, and it was immediately recognised and dealt with. So the NAP5 is linked with a parallel project in Ireland, and the quantitative analysis of the baseline, the activity survey and the reports of AAGA were very similar to those in the UK. But I suppose it's the qualitative analysis of the cases that was most helpful. Of the 11 reports in Ireland, shows a remarkable similarity to those observed both in the UK, in both their detail and themes emerging. It was the first ever large-scale anaesthetic audit in Ireland, as I said, and first study on AAGA. It involved the whole anaesthetic community. We had 100% response, and we're very grateful to all the anaesthetists, and in particular the local coordinators, for making this a successful project. As I say, 100% participation perhaps wasn't anticipated. In conclusion, a NAP5 Ireland report stands alone as an examination of the topic in a country separate from the UK. The similarity in the outputs from Ireland to those from the UK, we feel, serves to validate the process. And our next steps will be to implement the recommendations. There are many of them, but I think within our training programs and our CPD for consultants, it'll benefit patients and anaesthetists. And hopefully we'll live up to our motto, which is Salus dum vigilamus, which means safety while we watch, being vigilant. And it's a stepping stone, we hope, to other national and hopefully other international, even NAP projects. This is the report which you've all got today. We received this at the college yesterday in Ireland, and they were all delighted. It's a nice report, nicely presented, but I don't know who picked the colour, but that was particularly, they were delighted with the colour, and there was a big discussion which of the 40 shades of green it is, and I think they decided it was a mint colour. And it's greening of the naps. That's the expression we use on Patrick's Day when all over the world buildings are greened, and this greening of the naps. So we are actually very grateful to both the college and the association for listening to us, and that we wanted to be involved in what we feel has been very successful naps. Tim and JD have been very helpful to us. I'd like to thank Wouter, who was a trainee with me when they started, and I met him on the corridor and asked him to be involved, and I think he's regretting it ever since. But it's been a fantastic experience for us in Anesthesia. We feel it'll be very good for our patients, for patient safety, and again, thank you.